Can you see my screen? Can you see my screen?
सर आई कैन नॉट किसी और से पूछ लें.
Acha, let me check again if I'll be able to share my
Yes, sir. The
screen.
screen is visible.
Okay, थोड़ा सा मूव करें, आपको मेरी स्क्रीन नजर आ जाएगी बेनजीर. Okay,
ओके सर.
let's go further.
Yes, sir.
I was
Yes, sir.
I was trying to communicate here. Sorry. About the, okay. So this was the slide which I was covering last time. So the residual symptoms are unfortunately a problem in majority of the situation. And I was requesting all of you people that when you are treating major depressive disorder, make sure that you treat adequately, because if there are residual symptoms and they persist over the period of months, then the patient goes into the chronic phase, and chronic problems are usually difficult to manage and understand. So make sure that people are treated adequately. International Consensus Statement on Major Depressive Disorder, ICSMDD. Existing treatment guidelines have the following basic principles in treating patients with MDD. 1. Establish a correct diagnosis by using screening and diagnostic tools. I'm sorry, please mute yourself. Thank you. Okay. Establish a correct diagnosis by using screening and diagnostic tools along with the full clinical psychiatric assessment. So whenever you are seeing people in the clinics and the outpatient department and other places, make sure, I know that most of the time we don't use the screening instruments, but try to make sure that you have done an appropriate mental state examination and have asked majority of the symptoms related to depression. Second, assess the patient's depression severity, current stressors, comorbidities, and suicide risk. Select a treatment setting, inpatient versus outpatient, depending upon the severity of depression. So if the comorbidities are complicated, if the stressors are significant, if the suicide risk is imminent, don't hesitate to admit the patient. Establish a therapeutic alliance and educate the patient and the family about depression and its treatment outcome. Choose appropriate individualized treatment of an adequate doses. बार बार focus इस बात पे है कि adequate treatment, adequate doses, and duration to help the patient in achieving the remission. That is very, very important. And again, these guidelines also say that educating patients and their families about depression and its treatment and the goals of the treatment is important. Discuss antidepressant and their potential side effects. Drug to drug interaction. So if a person is diabetic, hypertensive, most of the time this happens, a common phenomena, then you have to make sure that whatever medication you are giving, it should not have interaction with other medications. Time needed to feel an effect and the importance of adherence. If the medication is discontinued, it's a complication. If you miss the dosage, it's a complication. So Rekha, if you cannot see the screen, and you are on your cell phone, try to move your cell phone screen and you will be able to see it. Don't worry about it. So just move your screen and you'll be, and if you're on the laptop, then it's easier, right? Okay. So, and addresses any fears about taking the medication. Most of the people, they feel that these antidepressants are addictive because people say so. 90% of the gynecologists, when my patient goes to the gynecologist, they say that don't take these medications because they are addictive. Unfortunately, we have to educate our other specialty professionals as well to ensure that these medications are safe in pregnancy. Antidepressants are which are there, you can use safely in pregnancy and make sure that the patients will get better. Describe the treatment plan and assure patients that the problems will receive immediate attention. So there are some medications which are given for the short period of time to make sure that the patient is comfortable, and there are medications which are given for a longer period of time to achieve the remission that I was talking in the first two slides, and make sure that there is no relapse or recurrence. Antidepressants are the first line therapy for moderate and severe depressive disorder. Unfortunately, most of the patients presenting to us, they never come with mild symptoms. So mild symptoms usually, yes, psychotherapy helps, religious therapy helps, yoga helps, exercise helps, and there are so many other options available. But for major depressive disorder with moderate to severe symptoms, only the drug therapy is the first line. SSRI, SNRI, NDRI is preferred due to tolerability profiles. SSRIs are usually the first line. Most of the psychiatrists, most of the physicians, they prescribe SSRI. SNRI are given but relatively less, and norepinephrine dopamine reuptake inhibitors are prescribed as the third line, not as the first line, but they are actually the first line. So if I see my patient and he is having symptoms where I feel that SSRIs and SNRIs cannot be given, my first choice as a first line treatment for MDD would be NDRI. So consider psychotherapy as monotherapy for mild depression. And as I was saying earlier, that most of the patients who are ending up with psychiatric treatment facilities and psychiatrists, they are usually moderate to severe, where the first line antidepressant needs the intervention. Benzodiazepine as monotherapy are always avoided. So benzodiazepines are not antidepressants even for mild depression, even for moderate and severe. So don't give them as monotherapy. Treat to remission and monitor progress after remission. That is important too. Assessing response and remission. So there are various scales that can be used, and if you don't want to use the scale, even then it's okay. So the symptoms that the patient presented in the beginning, say sadness of mood, suicidal ideation, or symptoms something like that, you make sure that they are documented or you know them, and in the follow-ups you are able to assess those symptoms back again to make sure that he is or she is responding to the medication, and make sure that the patients are not developing the side effects. Now there are some side effects with all of these medications which we usually don't ask, like sexual side effects of the SSRIs and SNRIs are never ever asked. And even if they are asked or conveyed by the patient is reassured and they are not addressed, which is unfortunately a complication. If a patient is having a sexual side effect, if a female patient is having a sexual side effect like SSRIs can cause anorgasmia, and the patient says that I don't have orgasm with the SSRI, please take it seriously. Don't waste it because she's a female or he's a male, and because you feel that this is not important as compared to depression, this is not the situation. You have to address it and ensure patient that he should be adherent to the treatment. Second generation antidepressants in major depressive disorders. So there are lots of studies available that the second line drugs can help, and there are majority available that second line drugs cannot help, but it's controversial. I still perceive that there are times when my patients have been to number of psychiatrists and they are falling into the domains of the resistant depression or chronic depression. I do try some second line drugs as well. Response and remission rates generally similar between the SSRIs and the newer classes. So the new drugs they have their own benefits. They have less of the side effects. They have more effective role in cognition. They are more effective in sexual dysfunction. So you can prescribe them, and they are good drugs. So why not? Okay, remission rates, SNRIs and SSRIs. So venlafaxine versus paroxetine. Now, there are debates and various research papers quote variably. So I won't focus on this slide, but I can tell you that there are patients who can respond best on venlafaxine and there are patients who can respond best on paroxetine. It's your choice what actually you feel should be given, and don't hesitate to prescribe. Pooled analysis of double-blind studies, bupropion versus SSRI. So there are evidence that bupropion can help. Escitalopram is a good drug. Paroxetine is a good drug. Bupropion is a good drug. In all of these drugs, I'm not recommending one over the other, no matter what the studies suggest. One thing I will definitely recommend and emphasize is appropriate dosage. So when I see psychiatrists writing escitalopram 5 milligrams per day, I literally cry. When I see psychiatrists prescribing paroxetine in major depressive disorder 12.5 for 3 weeks or 6 weeks, I literally cry. When I see psychiatrists prescribing bupropion 75 milligrams per day for 6 weeks time period, I cry. Don't make me cry. So if you want to treat, it has to be treated properly with the therapeutic recommended dosage of these medications. I hope I'll be able to cover some of them later. ये एक छोटा सा शेर, ये कैसा फीका चांद है रात के मैले आंचल पर. Usually when I quote this poetry, I never mean that it's something romanticism, but it is the romance with psychiatry. So the previous slide, when I was describing to you, don't make me cry, prescribing wrong dosages of the medication as a psychiatrist, this verse is related to that. ये कैसा फीका चांद है रात के मैले आंचल पे. एक तो psychiatrist and then prescribing subtherapeutic dosages. It's unfortunately complicated. Now, key issues in managing MDD and achieving remission. One, MDD is a heterogeneous disorder. Symptom profiles vary widely among individuals and between episodes. Response to antidepressant is inconsistent and unpredictable. Residual symptoms are common. Side effects negatively impact compliance and long-term outcome. These are the 4 important crucial points. Please try to remember them. 1, it's not something that a patient comes to me and I will prescribe escitalopram to every patient coming in outpatient department. No, it has to be individualized. Make sure that you know the previous record, what treatment response occurred in the past, and then try to decide. I still prescribe tricyclic antidepressants to my patients. Most of the psychiatrists, they have left it. I still give clomipramine up to 200 milligrams per day in major depressive disorder. And there is evidence that people do respond to it. Response to antidepressant is inconsistent and unpredictable. This is unfortunately not me saying it. These are the scientific literature available and it says it. Residual symptoms are common. So as I told you earlier, we never focus on them. We never focus on attention span. We never focus on the sexual life. We never focus on interacting socially with the people. We never focus on the gastrointestinal symptoms that patients usually have, or the urinary tract symptoms patients usually have as a residual symptom of major depressive disorder, which creates a complication. So make sure that you know them. And make sure that you are addressing the side effects of antidepressant as well. Nearly 1/3 stop the treatment in first month. Majority of my patients, if I prescribe them antidepressant and they start taking it and they develop side effect, they will go away. They will never come back. And this is tricky. About 44% no longer take the treatment after 3 months. Either they are okay, so they stop the treatment, or they are not okay and they are developing the side effects and they stop the treatment. And the early dropout, 28% by week 4, 43% by week 8, and 52% by week 12. Now, when I'm sitting in an outpatient clinic and I'm seeing the patients, and people who work with me, they know that very well. Lots of patients are coming to me with poor compliance, with just leaving the medication because they were okay and they left the medication and they had a relapse. And I am literally furious sometimes trying to educate them, frustrating that they have to understand this is a chronic, remitting, and relapsing disorder. And that consumes more time than writing the prescription. So you have to, again, be careful about these things. Adverse events, a major cause of treatment discontinuation. So you have given bupropion. Patient develops agitation. He will leave the drug. You are gone. You are end. He will go to another psychiatrist. The next psychiatrist may be competent, may be non-competent. If he's a competent, he will move forward and make sure that he won't give the bupropion back again because patient develops agitation with it. But if he is under the influence, he comes under the influence of the other psychiatrist. So Professor blah, blah, blah saw the patient and prescribed escitalopram 20 milligrams per day. Patient developed a sexual side effect. Let me do the same and reassure the patient that you won't develop the sexual side effect. It won't happen. He will definitely develop the sexual side effect with the same dosage of the escitalopram. And if you go give less dosage, I will cry because he will never respond to the treatment. So it's complicated. Adverse events, 60 to 66% of the patient cited adverse events as a major cause of dropout. 66%. So every second patient will leave the medication because he develops the side effect. Gaining weight, having insomnia, developing agitation, developing sexual side effects, which are the common side effects of the antidepressants. So they leave the drug. So if a patient develops a side effect, make sure that you address it properly. Lack of education about what to expect from antidepressant. I have prescribed antidepressant. Now the patient feels, okay, and I feel that there is no need to explain that there are side effects with these drugs. If I'll explain it to the patient, then patient probably won't start taking them because there are so many side effects. And I always quote, have you read the side effects of the paracetamol on the internet? They will say, no. I said, how many times you take the paracetamol? Well, very frequent. Go back, read the side effects of the paracetamol. You can die with 20 tablets of paracetamol taken together, but you will not die if you take 20 tablets of escitalopram together. That is the safety of the escitalopram or any other drug that I'm prescribing. I'm just quoting one example. So I usually try to convince my patients that the side effects, anything goes from here in, it will have an effect, it will have a side effect. So we have to overcome the side effect. We cannot avoid them. And if the homeopathy and other people say that these are absolutely without any side effect, if something is without side effect, it won't have any effect. And unfortunately, that's tricky. So you have to be justifying your prescription appropriately. Side effects of antidepressants: nausea, sedation, insomnia, sexual dysfunction, weight gain. Most of the people say that antidepressant with SSRIs, you won't gain weight. No, that's not true. People do gain weight with the SSRIs, and it's huge as well. So you have to be careful. So half of the time, my time is spent on educating people the importance of the diet control and importance of the exercise along with the medication, along with the psychological help, along with the social adjustments and other parameters. So it's hordes of time that you have to spend with the patient. Unfortunately, this is the fact. Although risk of the side effects may deter patients from accepting treatment, they should be informed the risk of untreated depression probably outweigh risk of the side effects. What is better? Remaining in this misery, in this curse, in this unfortunate situation, or having some of the side effects. So you have to weigh the risk and the benefits. And I'm sure people will say that, of course, this is more miserable than having some side effect like the weight gain. So we can address the side effects later on, but first target is to get you better. Nausea, an early common side effect of SSRI and SSRI, associated GI adverse events can lead to poor compliance, premature termination of the treatment, and compromised long-term efficacy. Gut mucosa enterochromaffin cells secrete 5-HT. Rapid dissolution and absorption of SSRIs leads to upper GI high mucosal drug concentration. Nausea from 5-HT3 receptor stimulation in the peripheral duodenal synapses is the cause, unfortunately, which needs to be addressed with the SSRI. Optimizing rate and site of SRI absorption should minimize the incidence and severity of nausea. Now, how to do that? So if a person is developing nausea with an SSRI, then how to overcome the nausea and keep giving the SSRI? That is a tricky question, and I will definitely like your feedback into it. So acid-resistant enteric coating system. Now, this is related to paroxetine-controlled release. I'm sorry, as I told you earlier, that this presentation is related to the specific drug, which I did present in long time ago, but I wanted to present, so this presentation was readily available to me, so I started presenting it. So most of the drugs which are enteric coated, so most of the psychotropics are absorbed from the first part of the ileum, right? But if you want to make sure that these are film coated tablets, they are not absorbed from the first part of the small intestine. They are slowly dissolved and are absorbed, and they are film coated. The chances of having nausea as a side effect will go away. So the nausea with raw SSRI is more. Nausea with film coated SSRI is less. Similarly, nausea with uncoated SNRI is more, and if it is film coated, enteric coated, it is less. So, simple choice. Use medication which are film coated. Then, sexual side effects, weight gain, fatigue, anticholinergic side effects, agitation, and insomnia. These are the common side effects, and we have to address them. Okay, any questions so far? How many people do we have here? Oh, half of them left.
सर जी डिस्कनेक्ट हो रहा है.
Okay, okay. So I don't know disconnect हो रहा है या लोग interested नहीं है. But anyways, whatever is the situation. Any questions so far? Any questions so far?
Yes, sir. I have a question.
Please go ahead.
सर अभी एक स्लाइड में आई थी कि जो है वो एंटी डिप्रेसेंट वर्सन कर देती है सुसाइडल बिहेवियर को, तो सर उसमें हमें फिर क्या देना चाहिए?
Okay, I haven't touched this topic yet. I am definitely covering this topic in times to come. आने वाली स्लाइडों में इसका जवाब मौजूद है. अगर मैं ये सारी स्लाइड्स कवर कर पाया आज within an hour, of course, I hope I'll be able to. I have about 20 more minutes, but there are 24 more 5-minute slides. There is an answer to this question. Do you want me to give it now, or should I cover the slides and come up with the answer?
Sir, you should cover the slides and come up with the answer.
Okay. ये सवाल मैं लाजमी जवाब कवर करूंगा. I won't miss it, so don't worry about it. Improving antidepressant tolerability. If the side effects become intolerable, consider lowering the dosage of antidepressants. So if the person is on 60 milligram of paroxetine, I will reduce it to 50 or 40, but I cannot discontinue it depending upon the response. If the side effects are still present, 2 weeks, consider switching to a different antidepressant and refer the patient to specialist if possible, so generally. Optimizing antidepressant dosage. Now, this is again, as I was saying earlier, if remission not achieved and the patient is not experiencing intolerable side effect and is adherent to the medication, increase the dosage of the antidepressant to a significant level. Reassess patient symptomatic improvement after 2 to 4 weeks using a measurement-based tool, which we have talked again. Oh, so there is another movie here. I don't know which movie is it. So let me see. अगर ये कुछ देखने वाली होगी तो मैं दिखाऊंगा, वरना मैं इसको फॉरवर्ड कर दूंगा. Oh, this was a song for the Naya Army Public School children. Anyways, I don't want to go for that. It will be length here, but definitely it was something that was touching my heart, so I felt it. Again, what next? Okay, what next? Switching and augmenting antidepressants. So if I have given an SSRI to my patient, which is say 20 milligrams of escitalopram, and patient is not responding, what should I do? Should I change it or should I continue with the same and augment it? These are the two strategies that we opt. So the first strategy, switch. Person is not responding to the current medication, I will switch to another SSRI or SNRI or tricyclic, whatever the treatment guidelines I want to adopt, and go for it. And the second option is that I augment it. Personally speaking, I usually go for the augmentation strategies first, and if the augmentation strategies fail, only then I will make the change, depending upon the situation. So if the patient has partially responded to 20 milligrams of escitalopram, then I will augment. If the patient has not responded at all to the current dosage of the SSRI, I will switch. That is the simple usual formula that I use. Partial responders usually to antidepressant treatment is a serious problem. We never take it seriously, but it is a serious problem. It requires aggressive therapeutic intervention, no matter how you want to do it, either with the psychological help or adding augmentation strategies. Now, if the person is not responding to the treatment, then things do get complicated and there is a problem. So, resistant depression, when the person took 2 antidepressants and is not showing adequate response, it is usually called resistant depression. Various definitions are there, but depression showing inadequate response, failure to reach insufficient remission following at least 2 courses of treatment of adequate dosage and duration with 2 different antidepressants from different classes is called resistant depression. This is actually the definition. इसमें कुछ ifs and buts हैं. Like कहते हैं कि 2 SSRIs from the 2 antidepressants from the same group like SSRI, even that is enough to qualify for this definition. Not necessarily 2 different classes. 2 different drugs from the same class can also lead up to the same situation. And this is a common dilemma in our clinical practice. In major depressive disorder, complete remission is the optimum therapeutic goal. And despite treatment, the first-line antidepressant, treatment-resistant depression, TRD, occurs in 30 to 40% of the cases. And the meta-analysis showed that 29 to 46% of the depressed patient treated with the standard dosage of antidepressant for at least 6 weeks failed to respond completely, and 15% achieved partial response, and 34% were non-responsive to the treatment. So it's very high, unfortunately. It could be because of comorbid anxiety disorder, comorbid panic disorder, suicidal risk, severe intensity versus moderate intensity, number of hospitalization, social phobia, recurrent episodes versus single episode, age of onset more than 18 years, melancholic features, non-response to the first antidepressant treatment, and personality disorder. All of these contributing factors can lead to chronic or TRD symptoms. 29% patients were chronically depressed over 10 years. Most predictive baseline symptoms: energy, loss, fatigue, loss of interest and pleasure, disordered sleep, thoughts of death, and suicide. Now, we never ask about the suicide, but if you ask directly, I usually ask direct question. If I perceive that this patient is suicidal, I will directly ask. कभी दिल करता है जिंदगी खत्म कर दूं, दिल करता है खुदकशी कर लूं, या दिल करता है कि इस जिंदगी से मौत ज्यादा बेहतर है, या मर जाऊं किस मुसीबत में फंस गया, then I definitely try to assess the whole of the suicide. So some patients are not resistant to treatment but are pseudo-resistant. Now this is again tricky. So important causes of pseudo-resistance, when actually there is no resistance: inadequate dosage. Just मैंने पहले कहा, escitalopram 5 milligrams or 10 milligrams is not an adequate dosage. Paroxetine 5, 10, 20 is not an adequate dosage. Venlafaxine 75 to 150 is not an adequate dosage. Similarly, for all other drugs commonly prescribed, sertraline giving 50 to 100 milligram is not an adequate dosage. Non-compliance, atypical pharmacokinetics, rapid metabolism, malabsorption syndromes, misdiagnosis, bipolar disorders, unrecognized comorbid psychiatric or general medical conditions, mood disorders secondary to substance abuse or medical condition, for example, hypothyroidism, unrecognized depressive subtypes requiring different treatment approaches, for example, psychotic depression, atypical depression, bipolar depression, seasonal affective disorder, and premenstrual dysphoric disorders all complicates the outcome. That is pseudo-resistant. So, treating partial responders in treatment-resistant depression, Correa et al. Compared olanzapine fluoxetine to olanzapine fluoxetine venlafaxine in TRD and partial responder. And olanzapine fluoxetine combination, fluoxetine alone, venlafaxine, and low dose of, again, this combination appeared to be similarly effective. So people believe, most of the research studies indicate, that combining medication in a way just to achieve the resistant depression may not help as we expect them. So we may have to understand that the treatment resistant depression, वो जो पिछली से पिछली स्लाइड थी, इनको हमने rule out कर लिया है before giving a combination, right? So assessment is crucial to intervention. If assessment is good, intervention will be good. If assessment is not good, intervention won't be good. Treating residual symptoms. Again, going back to the first slide. Sleep disturbance 44%, fatigue 38%, lack of interest or pleasure 27%, symptoms, side effect, or comorbidity. This is crucial. I have to assess whether this is a symptom, this is a side effect of the medication I am giving, or this is a comorbidity. If I'll be able to assess this rightly, I'll be able to treat them completely. If I won't be able to assess it completely, whether this is a symptom, side effect, or comorbidity, I won't be able to address the symptoms. So significance of disturbed sleep in depression. लोग बोलते हैं डिप्रेशन में नींद नहीं आती. मैं कहता हूँ जी नींद तो सूली पे भी आ जाती है. So my target is not initially to correct the sleep in the beginning. My target is to correct the MDD. If MDD is corrected, the sleep gets better. If MDD is not corrected, sleep will never ever get better. So, additive effect in reducing quality of life. Persistent residual symptom after antidepressant or CBT associated with increased risk of reoccurrence. Pittsburgh MTLDD maintenance treatment study indicates that patients do have insomnia even after patients recover from other symptoms of major depressive disorder. So this is one of the residual symptoms that people keep on complaining about the quality of sleep. Again, it could be because of the residual anxiety symptoms, or it could be primary insomnia secondary to MDD. And it is increased, associated with increased risk of suicide, and it is usually difficult to treat. Antidepressants versus CBT, which is better? As I told you earlier, in mild to moderate cases, CBT can work. But most of the patients presenting to us in a psychiatric treatment facility, they are suffering from moderate to severe and they need antidepressant. Combining CBT will reduce the chances of relapse, will address the symptoms of comorbidity, will help in having better outcome of major depressive disorder, combining CBT. Short-term benzodiazepine used for anxiety symptoms and treating insomnia is good. So my prescription usually is, if I write escitalopram for MDD, I will write tablet escitalopram, 20 milligrams, half a tablet for maybe a week or 10 days, and then pushing it up to 20. If I have carefully assessed the patient for comorbidities like bipolar disorder, I will do that. If there is a slight possibility that the patient will go into mania, I won't do that. So I have to be careful. But usual treatment for MDD, moderate to severe cases, I will go for 20 milligrams of escitalopram, adding a benzodiazepine, which will be tapered off in about 3 to 4 weeks' time, right? And then gradually getting rid of it. Modafinil treatment as an augmentation strategy. People don't know much about modafinil. It's available in Pakistan. It's a good drug. If a person tolerates it, I definitely add modafinil to an SSRI if I'm suspecting TRD. And it's a good addition to address the somnolence and fatigue. Lithium. I try to add lithium. Unfortunately, again, if the preparation is good, available in Pakistan, then I will definitely go for it. If the patient won't be able to find a good preparation of lithium, I will try not to do that. So the preparation, good preparation means that the density of the lithium salt, it has to be a firm tablet. If it's a powdery tablet, I won't give it because the efficacy will be compromised. एक अलग से debate है. Buspirone, I do write as an augmentation strategies anything between 10 to 40 milligrams per day in addition to SSRI in TRD cases. Thyroxine, atypical antipsychotic are good drugs to be added as well, but adding an antipsychotic will be my last option in TRD. The first treatment will be either with bupropion, with buspirone, with mirtazapine, with the combination of the treatment, or bupropion and duloxetine, SSRI, and many more. So there are multiple drugs that you can give. एक मोहब्बत काफ़ी है, बाकी उम्र इजाफी है. So this is the probably crux of the matter. I think I do have few more slides, but I hope I have covered. What is this? Okay. Okay, Manto. मंटो की बात इसलिए की थी कि मंटो remain admitted in mental hospital Lahore, and probably he was admitted at least 3-4 times uh, before he passed away. So unfortunately, that is a complication. So Doctor, your question about SSRI, can you say it again?
Yes, sir.
Go ahead.
सर आई आस्क अबाउट कि एसएसआरआईज जो है वो हम नहीं देते क्योंकि सुसाइडल बिहेवियर को बढ़ाते हैं, तो फिर हम क्या देते हैं?
Okay. Now, the answer to that question, which probably I will be covering later on, but I don't want to cover it here. मेरे ख्याल है वो slides extra हैं कुछ. So, उसका आंसर मैं सिंपल ये दे दूं कि यूजुअली तमाम SSRIs जब इनिशियली जब प्रिस्क्राइब की जाती हैं किसी को भी, तो वो साइकोमोटर एक्टिविटी को एनहांस कर देती हैं, राइट? आपकी साइकोमोटर एक्टिविटी बढ़ जाती है, जिस्म में हिम्मत आ जाती है, लेकिन सोच आपकी अभी भी डिप्रेसिव होती है, तो पेशेंट में सुसाइडल रिस्क बढ़ जाता है। अगर मैं उस रिस्क को ख़त्म करना चाहता हूं तो मेरे पास 2 ऑप्शन हैं, क्योंकि SSRIs को 3 हफ्ते लगेंगे उस सोच को बेहतर करने के लिए। फिजिकल सिम्टम्स हफ्ते 10 दिन में बेहतर होना शुरू हो जाएंगे, एनर्जी आना शुरू हो जाएगी, उठना शुरू कर देंगे, सुसाइडल टेंडेंसीज बढ़ जाएंगी। सो मैं बेंजोडाइजिपीन ऐड करूंगा फॉर फर्स्ट 3 to 4 weeks. That is the ideal thing that I do usually, and in a good dosage so that the patient's psychomotor activity is not lifted to a level where he tries to commit suicide, till the time his thought process is balanced at the same level. I don't think I will go for any other option but this one. But if the patient is at a risk that he will take an excessive dosage of the medication, or if he will commit the suicide, so I may give for the in a short period of time some drugs like olanzapine in a low dosage for initial 2, 3, 4, 6 weeks time, or ideally benzodiazepine, or try to give him some other drug. But honestly speaking, whatever the drug you want to give, even if the tricyclics, if the patient is having a high risk of suicide, he will try to commit suicide, so he needs supervision. Ideally, I will hospitalize him, keep him there for about 10 days, and when he starts responding to the medication, then I will discharge him. Got the answer?
Yes, sir. Thank you, sir.
Okay. Okay. Thank you very much, all of you, for listening to
Sir, I
me.
have two questions. I have
Go
two
ahead.
questions. So my first question is, how do you address persistent insomnia in patients with depression, because it is often a residual symptom. तो आप long term में benzodiazepine तो नहीं दे सकते ideally. So how should we address that? पहला question ये है.
Second question. Do you want me to respond to
Second
it?
question.
Sure, go ahead.
Yes, I want to it. Or should I ask both questions एक साथ ही?
चलें, मैं आपके पहले सवाल का जवाब देता हूं, फिर आपका दूसरा सवाल सुनते हैं। पहला सवाल का जवाब. So, as it is one of the symptom of depression, so the insomnia is one of the symptom of major depressive disorder, and if I have treated the major depressive disorder and patient after 6 weeks it starts complaining of insomnia, persistent insomnia, although there is no other residual symptom, so his cognitive functions are fine, he's started working better, his general outbeing is better, well-being is better, and he's still complaining of insomnia, my options are 3. 1, I can give trazodone 25 to 100 milligrams for sleep problems. The trazodone actually is having a good impact on stage 3 and 4 cycles of the sleep. So it gives more deep sleep, shorter half-life of 5 to 7 hours, no hangovers in the morning, so it can help. and it will act as an augmentation strategy. One. Second, I may give melatonin, which is an over-the-counter drug. It is a good sleep agent in some of the cases, but the dosage has to be very appropriate. The dose is either 6 to 12 milligrams per day. So most of the melatonin tablets available in the market are 3 or 4. So maybe you have to give 2 or 3 tablets per day, but they should be taken with the meals and 3 hours prior to going off to bed. Otherwise, melatonin will not help. So if you want to give melatonin, it has to be with the meals, not empty stomach, because it is not absorbed properly then. And with the meals, it is absorbed properly, but it starts its effect 3 hours before going to bed. Third option, I can give quetiapine in low doses, maybe 12.5 to 25 milligrams per day. But I prefer not to do that because it's an antipsychotic and people do feel bad. If any of these options help, it's good. Otherwise, I will try to augment with mirtazapine. Mirtazapine will be my last option as an augmentation strategy to treat TRD, because mirtazapine unfortunately makes people gain weight, or they also have hangovers, and they also cause psychomotor retardation. So that will be my fourth option. So first option trazodone, second option melatonin, third option quetiapine, fourth option maybe mirtazapine. Got the answer?
यस सर, थैंक यू सो मच। और
और
सर जो मेरा सेकंड क्वेश्चन है वो ये है कि जो मोडाफिनिल है उस आपकी क्लिनिकल प्रैक्टिस के अकॉर्डिंग पेशेंट्स का उस पे मतलब क्या रिस्पॉन्स आता है और वो डेली डोज हमें किस में देनी चाहिए और रिस्पॉन्स कैसा होता है पेशेंट्स का?
Okay. Now, important thing, modafinil, unfortunately, तमाम दवाइयाँ जो मैंने पहले चंद स्लाइड्स दिखाई हैं उनको अगर गौर से आप सुने तो मैंने बार बार कहा था कि डिप्रेशन में अनफॉर्चुनेटली रिस्पॉन्स कम है, क्रॉनिसिटी ज़्यादा है, हमें एग्रेसिवली इसको ट्रीट करना है वरना चीज़ें कॉम्प्लिकेट हो जाती हैं। मोडाफिनिल is one of the options for augmentation strategies to treat the TRD, treatment resistant depression. 100 मिलीग्राम की गोली होती है, यूजुअली 50 से आप स्टार्ट करते हैं और 100 से 200 तक आप जा सकते हैं. Again, as I said to you earlier, the response rate is about 33%. ज़्यादातर अगर आप मेरी पिछली स्लाइड्स को दोबारा गौर से देखें तो TRD 30% पेशेंट्स में डेवलप हो सकता है, चांसेस होते हैं. So modafinil is a good augmentation strategy to try to treat TRD. 100 milligrams per day in the morning. Chances of improving with it are about 60% to 70%, but 30% chances are patient won't respond. 30% chances also includes the patient may develop side effects and leave that drug. So we have to be careful. But this is one of the options that you can go for in TRD.
Acha, thank you, sir. And sir, what are the common side effects reported with modafinil?
Oh, modafinil's common side effect is agitation, aggression, precipitation of psychosis, maybe sometimes insomnia, because it is treated to activate the person, elevate the mood. So sometimes those are the complications. Those are common side effects, actually.
Okay, sir. Thank you so much.
Okay, you are more than welcome. I don't know how much I was able to help you people.
Sir, it was a wonderful presentation. नहीं, बहुत अच्छा था. वो actually दरम्यान में link कुछ issues आ रहे थे, आप mute हो गए थे. So इसलिए वो थोड़ा सा issue हुआ, वरना it was very good.
कोई मसला नहीं, ये जो unfortunately technical difficulties हैं चीज़ों को complicate करते हैं, but all is well if it ends well. I hope it was helpful to you. or let's try to do some other thing some other time, right?
Yes, sir.
Thank you, Benazir, for organizing everything.
You're welcome, sir. Thank you to you. सर आपने लास्ट टाइम बताया था कि आप किस कंडीशन में कौन सी एंटी साइकोटिक प्रेफर करेंगे, आपको उनकी डोजेज वगैरह बतानी थी. सो वो मुझे एक दो लोगों ने कहा था कि मैं आपसे कहूँ, जिसने आपने बताया था ना कि आपकी चॉइस इस एज ग्रुप में डिफरेंट होगी और हर उसमें आपका क्राइटेरिया फर्क होगा. तो वो कह रहे थे कि आप कौन सी प्रेफर करेंगे या आप क्या कहते
So
हैं
you
कि
want to know
गाइडलाइंस
the
बता दें
dosage of
कौन सी देनी चाहिए और
antidepressants
किस
or
डोज में देनी चाहिए, उसके बारे में आप फिर अगर नेक्स्ट टाइम में जब भी आपके पास है बता दीजिए.
so you want to know the dosage of antidepressant or antipsychotics?
नहीं सर, आपने लास्ट टाइम एंटी साइकोटिक बताई थी उसके बारे में वो पूछ रहे थे.
Okay, okay. अच्छा, मुझे honestly भूल गया. Sorry about that. But antipsychotic की dosage, common antipsychotic की dosages like risperidone, if I start with
नहीं
it.
सर, आपने कहा था ये बताऊंगा डिफरेंट डिजीजेस में डिफरेंट.
Okay, different diseases में antipsychotic की
सर आपने
कौन
ये
सी
कहा था कि ये कहूंगा कि यंग एज में
बीमारी में
ओल्ड एज में
हो
फिर
सकती
स्पेशल ग्रुप्स में कैसे प्रिस्क्राइब करेंगे और क्या डोज, ये आपने बताना था लेकिन आपने फिर
चलो फिर अगली
somehow
दफा यही
skip कर दिया.
प्रेजेंटेशन कर लेंगे कि एंटीसाइकोटिक मेडिकेशन द डोजेज इन वेरियस इंडिकेशंस. ठीक है, अगली दफा ये कवर
जी
टॉपिक
सर.
कवर कर देंगे. बस हो गया, डन.
अस्सलाम वालेकुम
ओके,
सर.
थैंक यू वेरी मच ऑल ऑफ यू. सी यू, होप टू सी यू सम टाइम सून. अल्लाह हाफिज.
थैंक यू.